Hello and welcome everyone. I'm Lia Mix, CEO of Delphi. Welcome to Delphi's July Insight session. Today, our guest has spent over 2 decades doing the patient, unglamorous work of rebuilding psychiatry from the ground up. Dr. Will Van Derveer is a psychiatrist trained at Vanderbilt University and the University of Colorado, and the co-founder alongside Keith Kurlander of the Integrative Psychiatry Institute and Integrative Psychiatry Centers in Boulder, Colorado. Over the past 20 plus years, Will has trained thousands of clinicians around the world in integrative and psychedelic-assisted psychiatry and therapy, and has served as a co-investigator on MAP's co-sponsored clinical trials studying MDMA-assisted psychotherapy for the treatment of PTSD. Will just released a new book with Keith Kurlander titled Psychedelic Therapy, which has become a New York Times bestseller. And Will joins us today at a moment when the field he helped build in relative obscurity is now facing an entirely new set of pressures: scale, speed, regulation, and the question of who gets to do this work as it moves forward into the mainstream. Please join me in welcoming Dr. Will Van Derveer. Great to have you with us, Will.
Thank you, Lia. It's a pleasure to be here. Thanks for having me.
My great pleasure. And we are both sitting in Boulder, Colorado, so it's quite a delight to have a fellow Boulderite on the Insight session today. Although you're in Boulder, your impact has been much more broad than that. And I'm really excited to talk about that. And also your perspective is much more broad. You've spent decades really building and looking at this field, not just in the US, but internationally as well. So just excited for this conversation, and also just excited to be your friend and colleague here in Boulder.
It's an honor to be your friend and colleague, Lia. We've been working on the Rubik's Cube on different sides of the same problem for a very long time now. So it's wonderful to have colleagues, like-minded people who are doing the work. And the unglamorous word, I think, applies as much to your deep work as mine, behind the scenes, organizing stakeholders, getting people aligned. It's really important work and often invisible labor.
This is so true. And thank you for that. I feel seen. So thank you. Yeah, let's dig in here. I want to get a little bit of background first, set a foundation for where you are now and where you think things are going. You've described unresolved emotional trauma as the most significant root cause of psychiatric symptoms. Now, this is a view that's probably well outside what you were taught at Vanderbilt, right? So what happened that moved you from conventional psychiatric training and thought towards this integrative path?
I like to say I was minding my own business, trying to become a psychiatrist like other people in my class, in my education. I came out of residency very excited about practicing psychiatry. I had the tools that were available to me, that I was board certified to provide cognitive therapy, medication management, and so on. And it became very apparent to me very quickly how many people didn't respond to the conventional treatments. And it was very disturbing. It was devastating, honestly. I saw a future where my work as a psychiatrist was going to become a kind of carousel of medication changes and diminishing results. And there was a big study that came out right after I graduated from residency called the STAR-D trial that confirmed my concerns about the effectiveness of the conventional tools. And we could go down that rabbit hole and talk about that evidence, but essentially every time you change an antidepressant, you get less and less chances of benefit. It's pretty discouraging for many people. So I set out to try to understand what was wrong with what I learned. And I started out with integrative medicine and learning about gut-brain connection and hormones and inflammation and infections. And I started running stool tests on psychiatric patients. And I was starting to build a fuller toolkit. And that helped more people than the conventional toolkit, but it still left a lot of people struggling. And then I trained in a somatic psychotherapy for trauma, and I was doing somatic therapy. But it wasn't until I got involved with clinical research with MDMA that you mentioned earlier with MAPS, and I began to see how quickly psychedelic therapy could change the course of someone's life who had been struggling for decades, that I felt that we were starting to get somewhere in the field. So that's the summary of a 20-year trajectory.
Amazing. Thank heavens too that you were attuned to what was happening. I was a clinician back in what I consider the bad old days, early 2000s. We just saw people making tiny, slow progress, if any, and a lot of relapse, a lot of just struggle and suffering. And the moral injury was very real for those of us working in the field. And front runners and tips of the spear like yourself, I think have been so instrumental in bringing us new hope. Like change can be lasting, it can be permanent. People don't have to live out their diagnosis for the rest of their lives. And I think I'd enjoy being a clinician much more now than back then.
It's true. It's no fun living inside of the belief system, let alone communicating to clients. You are going to be in this system forever. You're going to take these medications forever. You're going to be dependent on mental health care forever. It's not anything that we sign up for as providers. But now we have more effective tools that I think actually help us put our money where our mouth is in terms of saying, look, we're going to intervene, we're going to do it in a short-term way, and we're going to get you back on your feet and get you moving on and put mental health care behind you.
And so it's a new day, and you've really helped shepherd that in. And part of that, speaking of new tools, is about psychedelics, right? And long before psychedelic therapy had any institutional legitimacy like it does today, long before that, you and your team were doing things like sending folks to Amsterdam with a camera crew to document psilocybin sessions. That's years before Oregon or Colorado legalized anything. And I'm wondering, Will, what those early, almost improvisational years training thousands of practitioners across 60 countries, what did that teach you that you maybe couldn't have learned any other way?
Gosh, we learned a lot in those days. um, there's so many ways to answer your question. I appreciate the question. I think that maybe the most useful answer is we learned that people everywhere really want the same thing. They want to experience the joy and freedom of having mental health challenges behind them. Providers all over the world want to have better approaches that are more effective, that are interventional approaches that don't condemn people to lifelong dependencies. We certainly had our fair share of challenging moments along the way, I would say, not the least of which has been navigating the state psilocybin rules in different states. That's been quite challenging at times. So I think I also didn't really appreciate what it was like to work inside of an emerging market that's not even emerged yet. There's a lot of infrastructure that you're helping us with, things that you don't really think about. How do you find liability insurance to work with people with psychedelics, right? This is a brand new thing.
Shout out to the National Psychedelic Association for
Yes,
their work
exactly.
on that. Yeah.
Exactly.
Yeah, so all of that infrastructure and having some things that are known to fall back on, things for safety, for example, standards of care, all of that hadn't been figured out yet. How do you identify who is right for the treatment and who isn't, right? So sure, those were some true adventures to be had. And you're bringing that into the present day. Before we shift into talking more about what's going on right now and what your perspective on that, I wonder if you might share a little bit about your personal story of how you got into psychiatry, how you got into psychedelic therapy. I was really touched by what you wrote in your book about this, and anything that you feel would like to be shared right now before we start talking about the book itself.
I didn't plan on going to medical school. It was very late in my senior year of college that I realized through joining a research project studying schizophrenia that the people that I met in that process were the people I wanted, the patients I had the privilege to interview in psychotic states, were I felt like they were my people. I wanted to be around them. And I realized that I needed to go to medical school to do that. So I came in with this idea that I wanted to be a psychiatrist, and I was counseled very assiduously by my advisors not to bring up that I wanted to be a psychiatrist in my med school interviews, which was funny.
Yeah.
They want you to be soft clay that they can mold and let them think that way. I got very excited about the biology of the body and the mind and the brain. And I almost went into a different direction in medical school. But I was driven by both conscious and unconscious wishes. And I think the conscious wish was to understand what's going on with the mind. What is mental illness actually? And how can we support people to move through that? But I think unconsciously, I was also aware on some level that there was a lot of unanswered questions and trauma from my own history, from my own childhood. It wasn't until I'd been in practice for about 10 years that it started to really dawn on me that there was a lot of trauma for me to face in my own life.
Yeah. Yeah. I resonate. I truly do. And something that you said just at the beginning of that was when I was with the patients, I felt like these were my people. I had a similar experience. I feel like it's this, we weren't encouraged to really look at ourselves in this way in behavioral health training. That's maybe you're supposed to do a year of therapy, take a little peek under the hood, but not really look at it. I just hear you in that there's some hurt inside where we see others suffering, and there's this draw in this connection. And for many people in the field, it does take a decade or more. Hopefully, they identify that there is trauma, unresolved trauma within themselves. And I think that's a huge change that's happening in behavioral health care is now that we have tools to look at trauma, to treat trauma, trauma-informed care is a thing.
It's a thing.
There was no books about that. There were maybe a couple of books about that, and now it's
Absolutely.
a huge focus thanks to folks like yourself. And speaking of great books, congrats on Psychedelic Therapy achieving bestseller status.
Thank you.
That's super exciting. And just a question about the why. So what were you trying to accomplish with this book, you and Kirk, that wasn't out there already?
As you mentioned earlier, Keith and I have been training clinicians for many years now. We started talking about writing a book together when it started to happen where we would be in public and we'd be in conversations with people who are not in the field, who would ask us questions about what we did. And we'd say, we're training thousands of people in psychedelic therapy. And like, whoa, what's psychedelic therapy? And so we realized that there was a big unmet need in helping, we call them lay people. It's not the great description, but people who are not professionals in mental health care to better understand the process and to do this from a sober, responsible point of view where we could discuss the drawbacks and who shouldn't be undergoing psychedelic therapy and who it might help, what's involved in the process, where do you go to get the services? Is it covered by insurance? How does that work? What are the differences between the different medicines? So we wanted to meet a general audience that has a lot of questions about, okay, if I'm a person who has depression and I've tried and failed an SSRI and maybe a different class of antidepressant, maybe therapy hasn't worked well for me. So these are the people who are often best served by psychedelic therapy, people who have tried and failed other approaches.
That's the perfect kind of segue to the next question. So that, first of all, thank you. That is a huge service to the field and to patients to offer this education that is so accessible to the medical and mental health community broadly. When we were having our pre-interview discussion, you mentioned something striking to me. You said most of the true believers in this field have already been trained. And now the wave coming through is largely unfamiliar with the work. And they're arriving at the same moment that pharmaceutical companies are pushing for faster, larger scale training, right?
Right.
There's this confluence. So how are you and Keith actually navigating that tension between training depth and training speed?
It's a great question. The tension is there between maintaining quality and depth and also meeting a huge need. So I don't think there's any easy or quick answer to that. One thing that we keep talking about is the need in the professionals in the space to continue to meet with each other and continue to get supervision and to continue to unfold the expertise that I think takes years to develop in this field. We can bring beginners along by having exposure to people who are much more experienced in these relationships. So I believe that didactic education, online education certainly plays a role. It builds a foundation. But I think that, and this has just been borne out in my own experience developing as a psychedelic therapist, that the relationships with people who are further along in their wisdom and their expertise and their depth can make a huge difference in how fast people become ready for the work. So I think it's a combination of different things. And obviously making use of the best technologies that we have available is huge as well.
Yeah, a lot of considerations there. And in some ways, I really commend you because we still are in building the plane while we're flying it mode.
Right.
So it takes people who are really paying close attention to these nuances to ensure that we are getting the right dynamics between speed and having access and depth and having safety and effectiveness.
I think building the plane as you're flying it is a great way to start understanding what's in front of us here, because my mother-in-law was texting me last week about how the plane isn't, there's some kind of mechanical thing and she's waiting on the tarmac and it looks like they have to change the plane. And I was really happy that they changed the plane.
Yeah. Right. When to change the plane and not to change the plane, right? We need to find all these things out. And it blends into a question about safety because the train stuff is left the station. We don't have the FDA approvals yet, but everybody feels it, senses it, they're coming. And we have state level therapeutic use programs, as you mentioned. Religious use is ramping up, recreational use is ramping up. And so what do you think about as we see all of this wider use? We're going to see more adverse events. So where do you see the biggest gaps right now in the system's ability to even recognize, let alone respond or prevent those events? And what needs to happen for this expanded access to actually be safer?
This somewhat goes into the reason that we wrote the book in the first place, is that there's a tremendous amount of risk reduction that happens in preparation. Many people who suffer adverse events have not been adequately prepared for what is in front of them. Screening is important too, that's for sure. But the set of beliefs that a person is bringing into their experience is critical to the outcomes. So we have this in psychiatry, and as a psychiatrist, I think it's fair for me to critique psychiatry from the inside with 25 years in.
Definitely.
That we've created a kind of a monster where the idea that the thing you put in your mouth or the pill that you take is the answer, is the treatment, is the entirety of what one needs to do to feel well, right? I have a serotonin deficiency, therefore I'm going to take Prozac and that will cure my problem. These are empty promises. And we have a culture that reinforces this view. And it's quite sad because through hard work on the back end, on the integration side, we can put mental health care behind us. But it's not going to happen if we subscribe to the view of the chemical cure.
Yeah.
So often when I see people in my practice or people we've worked with not getting well or having really difficult experiences, we haven't done enough on the front end to help someone understand what's in front of them in terms of the work that may be required to get well. So I think that represents a large percentage of risk reduction, but I think obviously we have to take care of guardrails around safeguarding and ethics and protecting the exquisite sensitivity of a person on a psychedelic and so on. I'm a little worried about short shrift on preparation and integration because most of the healing happens in the integration and follow-up sessions, not during the session. Yeah. These are some of the things I'm paying attention to.
Yeah, absolutely. And most of the prevention of adverse events happens in preparation and proper screening. So those are certainly things to be concerned about. And I just have to say how much I love the depth of your answer. What I was expecting is something more structural in terms of, oh, we need to have this in place and that in place. And you went right to the heart of a core issue in psychiatry and in behavioral health treatment in general, which is this ingraining of illness into the identity of the patient.
Right.
And that creating the obstacle to them ever being able to overcome and be in full remission. Like other illnesses, you can be in full remission. You don't have it anymore. It's in the past. So
totally.
Thank you for that. Thank you for that, identifying that as a safety issue and a risk for all of us. You've raised something also that I think is under discussed, which is not just who gets trained, but who gets to do each phase of this work. So preparation, dosing, integration, follow-up. In our prep discussion, you mentioned a model where veterans are supporting other veterans in post-psychedelic experience, almost like an AA community model, versus a sterile clinical one-on-one encounter. So I'm wondering, where do you think the field is headed on this? Towards more like clinical containment or towards more like community-based models for integration, or maybe both?
I think that we're going to move more and more toward community containment. I think that we're going to start probably more traditional, more conventional in a more clinical framework. But I think as people start to understand the role of community in wellness, after all, we have a lot of evidence. There's a lot of data to show that long-term wellness, longevity, the Harvard study of longevity, we know that deep, meaningful, nourishing relationships are critical for well-being. We're social primates. We're not orangutans. We need that. It's medicine. And it's also way more cost effective than standing up a lot of clinical frameworks. So my hope is that we can move more toward this mentorship and sort of AA style model of, look, I've been through this. Now I'm ready to help you get through this because I've been through this.
Yeah, I've so agree with you. And one of the things that I've noticed and really appreciate is the increasing value placed on lived experience.
Yes.
And how we are social animals and we need to connect with others who we can feel that they really understand the struggle that we've had, the path that we're on, that they're a little bit further down the road. And that gives us a sense that there is a way forward. There is a path forward. I love this vision, and I want you to keep painting this picture for us because you have this goal to train 10,000 clinicians, right?
Yeah.
And so I'm wondering, what does that future look like in your mind's eye? If we reach that kind of scale, what is psychiatry and what does behavioral health treatment look like?
if the goal is wellness that's sustainable, things get simultaneously a lot simpler and a lot more complex at the same time. The simplicity is that we have to cover the fundamentals for wellness to be sustainable. And that has to start with the basics like sleep, nutrition, relationship, hydration, physical activity, fresh air. This gets complex quickly because we start looking at social equity and access, and we start looking at environmental issues, and we start looking at pollution. And so it's a fallacy that is more extreme in mental health care than it is in physical health care, that the treatment is going to replace any of those fundamentals or be a substitute for them. So I think that I look toward some of the countries in Europe, in Northern Europe in particular. Our friend Flores lives in one of those countries where the statistics are way better in many of the health parameters that we follow compared to the US. And I think some of this is quite devastating when you look at how much we're spending on healthcare in the US and what the return is on our investment.
Yeah, it's so true. And it is there in the data. It's pretty black and white, where you have scenarios, countries, places, jurisdictions where there is actually more social models for healing that are funded, that are encouraged. You do have better mental health. And one of the conversations that's been coming up, and we want to switch to audience questions, but I just want to riff on this for a second, is how we've gotten to an extreme in individualism in the United States, especially over the last few decades, where a sense of community and contribution to community and showing up for one another, and therefore there being support and there being connection, that has been a through line in humanity, as far as we know, for the long haul, for the duration of it, until fairly recently, where it's been about the individual, especially here in the US. You, your goals, what you want, what you're doing, what your dream is, you. And it's really the I at the sacrifice of the we. And so I think that you're speaking to so many aspects of how that has negatively affected our overall well-being, whether it be food deserts or pollution or isolation. And so what I hear in your vision that I love and I share with you is a behavioral health system and community that encourages and even requires or fosters more of the we.
Yes.
Yeah.
100%.
Awesome. Great. Sign me up. Oh, we do have some questions from the audience if you're ready to shift.
Great.
Great. Oh, Jim, wonderful. Jim Smeating is here with us, who's an expert in pharmacology and drug development. Jim, your question, is there a move towards practitioner certification within this educational process? To you, Will.
That's a great question. Thanks, Jim. So we've been offering an internal certification for some years now, but there are organizations, and Lia knows probably more than I do about the national organizations that have been attempting to organize around developing a certification. So it's a little bit like taking psychotherapy to the FDA. There's not much precedent in terms of national certification around schools of psychotherapy, right? So you become a psychoanalyst by going through that training, and the psychoanalytic organizations provide a certification. You can go to an EMDR training and get EMDR certified in a couple of weekends. But it's a relatively new idea that we would go national with a particular school of thought with psychotherapy. But there are organizations that are trying to do that, and I think it's an important movement.
Absolutely. I think some of what we see is the usual drug developer issuing a certification for their drug to be administered, which is, I think most people would say, probably inadequate for these forms of treatment. There have been several groups that have tried to get some kind of certification, like national certification, together, which it's grassroots stuff. So it doesn't always go in the way that we'd like it to go in a linear way. And there's a lot of people out there that are doing training, that are offering certifications. So it's going to be really interesting to see what the system is actually willing to adopt and what gets written into policy when it comes to, for example, reimbursements, and if we get into under licensures and things of that nature. So very much playing out in real time. And there is no one global solution that's been formed yet, but we'll see where the field goes. Jim has some other really good questions here. Is treatment failure the first step in achieving insurance reimbursement? And what have your experiences been, Will, in pushback from the insurance carriers and success in achieving reimbursement?
Is treatment failure the first step? If we look at Spravato, for example, which I think it's a decent example because we have a REMS with Spravato. Spravato is esketamine, which is the left-handed ketamine that is a nasal spray that's indicated for treatment-resistant depression and also major depression from Johnson & Johnson. The third-party payers have required a documented failure of at least 2 medication trials to reimburse for Spravato. So that could be a model for treating people with treatment-resistant conditions with, say, psilocybin or other psychedelic products. I'm not sure how I feel about narrowing the funnel that way for people, that they won't have access to these drugs unless they have a treatment-resistant condition as defined that way. I think a lot of people would prefer to have an interventional model that is 1 or 2 or 3 exposures to the drug rather than having to take something every day that is almost guaranteed. The evidence says 80% guarantee of relapse if you stop your daily antidepressant in the future once you're on it.
Right.
But that could be a pathway to reimbursement. My therapy experience in my office is more with racemic generic ketamine, and that's been a cash pay basis. We can get some reimbursement for psychotherapy codes, but we haven't been able to get the whole treatment covered.
Right. All very good points, and how Spravato played out and so forth. We have several other questions and not enough time. So let's try and get through a few more of these.
Right.
These are really good questions. Are there good ongoing data and outcome studies that are underway that can show success and societal benefits of using these new agents and therapeutic support?
We are at the front end of that process in terms of improving society. I think we need a lot more data to see that. We have lower quality data, qualitative data, interview data, people talking about 1 or 2 sessions with a psychedelic causing lasting or permanent benefits to them personally. Right now, we're working on getting these indications for major conditions, diagnoses. So that's where the bulk of the research is at the moment.
Great. Thank you so much. Lynn Marie Morsky, fantastic, founder of the Psychedelic Medicine Association. Just great to have you here, Lynn Marie. Can you please discuss some of the ways to address the need for greater access to experiential or practicum type experiences for trainees, both on the therapy and the medical side? And your thoughts about using AI models like Fireside's Lucy as an example, or Saba also is working with an AI model.
Hi, Lynn Marie. Nice to have you here. It's a small world. The need for experiential education, I think, is substantial, and we've included it in our programs in the past. And it's not easy to pull off. It's expensive and complicated, and the risk liability is high. I think that when you get into this work as a clinician, you start to realize that there's a lot to learn, and many people want to have their own experiences to be able to talk about, as Lia pointed out earlier, that one's own experience becomes part of the conversation often about, have you had trauma or have you taken a psychedelic before? Do you know what that feels like? It's very vulnerable to make that choice. I don't have a quick answer to the how, but I agree that it's incredibly valuable to have experiential learning.
Yeah, if not essential. Just real quick back to the Spravato thing. The Spravato was delayed not because it wasn't going to be reimbursed, but because practitioners were afraid to administer it because they hadn't had experiential training.
Wow.
Smart.
Wow.
I don't want to shoot someone up with ketamine if I don't know. I haven't sat and been supervised doing that before and know what to expect. I certainly hope that people are going to have that kind of fear factor before they start thinking that they're going to sit with someone with psilocybin before they've had experiential training. This is a very different. I love Alicia Danforth's concept of you wouldn't want to learn how to scuba dive from someone who hadn't scuba dived before.
That's
So
right.
it can be a little dangerous. Real quick one from Donna Buzzle. I'm so happy to see you here, Donna. LCSW, who's a brilliant interventionalist, and she is asking, how do we get trained, Will? When is the next session available?
Please go to our website, which is psychiatryinstitute.com, and you'll find all the information there. We're currently registering for a September cohort at the moment.
Great. And Lynn Marie's just giving you a shout out, Will, and thanks for helping the Psychedelic Medicine Association with the accreditation program to accredit training.
Yes.
Thank you for
Yes.
that, Will. Rick Barnes, so great to see you here. So this is a really good example. Rick is a great example of the spectrum of care that we need to consider. And Rick is a sober companion. He is very well known in that regard, in that field. And he is very interested. He's here, he's showing up as well. And he's asking, do you have a medicine of choice, Will? Or do you find that certain psychedelics treat specific issues better?
The short answer is no. The longer answer is I think that each one has its own unique benefits. And I can say this very briefly. For acutely suicidal people who might need to be hospitalized, I think intravenous ketamine is a great option in the emergency setting. Oftentimes, not always, there are no alwayses in psychiatry, but oftentimes will have a huge impact on reducing suicidal thinking immediately. For long-term results, for durable benefits for depression, I think psilocybin is emerging as an incredibly great tool for that. But LSD is also nipping at the heels because last week, the top line data on the phase 3 trial of MindMed 120, I think is the name of the product, MM120 came in with a huge reduction in depression symptom scales. And then with trauma, I think MDMA therapy is probably going to emerge as the most supportive option and has incredibly durable outcomes as well. So they're all different.
Yeah, and some might be better suited to some indications than others. We're actually out of time, so people might start dropping off, but I want to squeeze in this last question from Elise Freed, who is an amazing person, filmmaker, philanthropist, champion of women's organizations. Thank you so much for being here, Elise. Will, this question, I think it's really great. How do we find the ailments for which natural medicines, I think she means instead of pharmaceuticals, can treat? There's a lot of oral tradition about this, and who's gathering that information, like for example, for Iboga, and how are we going about gathering the existing international data? And then how do we know natural medicine versus pharmaceutical?
Great question. We have a lot to learn about Iboga and Ibogaine. I hope that, to your point about building the plane as we're flying it, I hope that we take our time trying to understand this plant. It's incredibly complex. It's more complex than any of the other psychedelics by far. At least 50 receptor systems in the brain are impacted by Iboga. So it's fascinating. I spent a period of time in college studying anthropology and reading ethnographies from around the world. And I think we need to listen to the local people in Gabon. We need to understand how West Africans have come to understand this plant. And I think that's a good place to start.
Yes, absolutely agreed with you on that. Thank you for that answer. And Thank you for being with us, Will. This has been just a wonderful conversation. Thank you for sharing your wisdom with us and for all of the incredible contribution and work that you have done and you continue to do.
Thanks, Lia, for having me, and thanks everyone for showing up and asking such great questions.
Great. And we look forward to seeing everyone next month on our Insight session. Thanks, Will, and thanks everyone. Have a great rest of your day.
Thank you.